many of the studies that we were presented with today and yesterday, our experience with certain patient populations grows organically. So as someone with an immunology background, I get cases, a bit odd cases, autoimmune cases, and so on. So 3 years ago, I received a call from the co-founder of the Stevens-Johnson Syndrome Foundation, who has a child with who experienced SJS. And he was then 16 years old, and he had been exposed to an antibiotic for a day when he was 3 years of age and developed the full necrolysis syndrome that we'll review in a moment. And we'll be focusing on the ocular complications, but the reason she called me was not that. The reason she called me was that he was suicidal because he was living in a bubble. So he had developed total body urticaria to any stimulus. Heat, sunshine, noise. So he had to ultimately live in a dark environment like you would have to after TBI. And couldn't go out. He couldn't go to school anymore, had no friends, and she was desperate. And she decided that she wanted to take the risk of taking him to San Francisco to get IV deployment. And after a lot of discussion, we ultimately did the case. And I'll review this case with you, but this is a very good example of how you can take a complex disorder, in this case a rare and neglected disorder, and treat it both systemically and locally and get pretty profound results. So just a bit on SJS. It's pretty poorly characterized immunologically. This is a global systemic phenomenon taken even after a simple ibuprofen pill. So we don't know who is predisposed to getting this, and we just have no prospective information on who will get this. But there are many different, there are different forms, and all of the patients that we'll be discussing today had the toxic form on the bottom, where they're detaching skin from more than 30% of their body surface area. There are not very many good, nice-looking photos to show. These are all fairly dramatic. I try to choose ones before lunch that wouldn't be that distasteful. But this is a typical child reaction, predominantly on the skin. But there is quite a bit of organ injury. There's quite a bit of pulmonary injury, and there's a lot of injury on the mucosal surfaces, as well as the ocular components that Dr. Milstein will be talking about. This is how bad it can get in terms of the skin looking like it's cellophane paper. Now, one of the most injured areas are mucous membranes, the oral cavity, and then in this case in the eye. You'll notice, Dr. Milstein will talk about it in more detail, but you notice the tremendous inflammatory state within and around the eye. This is a patient in the midst of the immediate care, and he has an amniotic membrane sutured onto his eye to protect his cornea and the other architecture of the eye. But there is essentially no treatment per se for the ocular manifestations of this, and we'll discuss the long-term manifestations, which brings most of the patients to a center like ours. So again, Dr. Milstein can go over the ocular signs and symptoms of Stevens-Johnson syndrome, but they're quite profound and chronic, and lead to chronic conditions, chronic issues that the patients suffer from, including corneal damage, eyesight loss, a lot of pain, light sensitivity, the need for scleral lenses, and the inability to function without knowing that they have a chronic eye condition and a lot of discomfort from it. So we totally have done to date 5 patients with Stevens-Johnson syndrome. Again, the day after we did the first patient, literally the day after, the entire Stevens-Johnson syndrome population in the world knew about it, because it was posted onto their Facebook page. So it was a pretty phenomenal thing, and it even takes a year or two to get a patient to come from wherever they live over to us. So we haven't seen every patient yet, but I think we will be getting more and more of these patients. And they've been treated with a combination, 5 of them have been treated with a combination of both intravenous and localized periocular SVF. One patient has only received IV SVF. And this is an interesting case that you should be aware of when you're dealing with specialists that take care of your patients. This patient could not receive ocular deployment because the ophthalmologist told the parent, who is the founder of the SJS community, the foundation, that he would report her to child abuse if she underwent that procedure. The same holds true for the Canadian patient, my first patient. The ophthalmologist said that he would report her to the governmental officials, and she said that she'll take the chance and do it anyway. That makes it difficult to get prior records from these guys, but some folks feel very strongly that you should not muck with their patients. 2 patients had additional IV SVF deployments. One patient has had 3, the other patient has had 2. And we'll share our experience with all these patients today in a case report-like fashion. We don't have full follow-up on all the patients. But these are the 6 patients. And I don't have a pointer. The first patient was treated initially with IV therapy alone for his global body urticaria, and that was almost 3 years ago. This patient had to come in with sunglasses, and he had his entire body covered. This was done in the summertime in San Francisco, which is pretty cold, but he had to wear, he couldn't be exposed to any sunlight. He came in the next morning after his SVF procedure crying because he said he was let out of jail. For the first time in many years, he was able to walk in the sunshine and take a warm shower without going into a complete urticarial reaction. So it was pretty interesting, and within 24 hours, he had an immediate systemic anti-inflammatory effect. And then 6 months later, we eventually, with Dr. Milstein's help, we deployed his first SVF intraocularly, which we'll review in a moment. So you'll see here the ages of onset is anywhere from a young child, 11 months and 3 years of age, all the way into adulthood. So all populations get this. And then you'll notice non-ocular symptoms. I just wrote a few. They have significant global immunological and non-immunological symptoms. One of the more interesting ones is Ehlers-Danlos syndrome. The asthmatic, the second patient who had asthma, was considered to be the 3rd worst asthmatic in UC Davis history. So this is a very, very severe asthmatic response. And so we not only have the opportunity to look at ocular effects, but we also have to take a look at effects more globally and systemically. But we do have quite a lot of follow-up. Around 2 years of follow-up, 18 months to 2 years follow-up, and 4 of the 6 patients. So the first patient came as the second patient from Spain after hearing about the Canadian first patient. And she was affected when she was in her early 30s. She had limited tear production. She was unable to open her eyes without scleral lenses at night. She could not take her scleral lenses off and see anything at night. She was exhausted during the evening. And then she had this thing, which is very common, as Dr. Milstein will describe, ingrown eyelashes, which she had to have removed every single week. So this is some kind of aberrant proliferative reaction into the eyelash area. So in October of 2015, we gave her both IV and periocular SV deployment, and we'll show you that we'll show you one of those deployments on video, both into the subconjunctiva as well as into the lacrimal glands. And we gave her the remaining 4 cc IV. Interestingly enough, even sometimes the next morning you could tell the dramatic decrease in the eye inflammation immediately. And then she went on to an intensive, let's say, functional medicine or naturopathic anti-inflammatory protocol. This patient became so moved that she was feeling better that she didn't want to change her protocol and hasn't changed her protocol for over 2 years. And she's probably the most successful client that we've had. So one day after the SPF, she reported brighter eyes and less photosensitivity. She was able to check her emails that night without the lenses for the first time in 8 years. 2 months follow-up, the doctor examined her and was surprised that her inflammation was completely gone. She only had 2 lashes removed in the past 2 months, where she used to get it done every week. 4 months later, she took her scar lenses out every night and no more pain. So she was a computer whiz, and so this was her work, so this made her work a lot easier and more pleasant. 1.5 year follow-up, she was driving at night with a history of severe photosensitivity and swimming at the ocean without goggles. So this is pretty amazing. And almost go all day without remembering the Einstein. Okay, so I didn't realize we had 3 minutes, but because we wanted to definitely show the videos. 56-year-old man, extreme fatigue, chronic diarrhea, a lot of pain from his Ehlers-Danlos syndrome. He had no sweat glands. He suffers from heat sensitivity. Again, combination of IV and ocular findings. 2 days afterwards, he had no diarrhea. This is a 15-year history of chronic daily diarrhea and no eye pain or strain. And again, symptoms over the 18-month procedure, and he had a follow-up IV SPF procedure 12 months later, again for his knees and right shoulder, and he's improved. So I'm going to give it over to Dr. Milstein and let him discuss his part of the lecture.
Thank you, Ron. I think this has been a wonderful collaboration. I personally and professionally really enjoy our relationship. This could only have taken place without excellent doctors and colleagues who are willing to take the risk of being labeled anything other than professionals. And as far as ophthalmology is concerned, I'm going to get onto the dry eye discussion. Dry eyes basically is an inflammatory and immunoinflammatory reaction, and it involves T cells and hyperosmolarity, a number of other things as well, hormone desensitization, etc., and hormone imbalances. The application of stem cells or stromal vascular fraction has an immunomodulatory effect. And this seems to be part of the mechanism of action for this particular therapeutic modality of stromal vascular fraction and dry eyes. Part of the reaction is cicatricial, and that's where we get eyelashes ingrowing. So we get a cicatricial reaction to this process that can produce chronic pain and marked alterations in the quality of life. So without being an ophthalmologist, we'll go to the next slide. The whole process can affect the ocular surface. The tear film is composed of aqueous, water that contains a number of inflammatory chemicals. A mucin comes from goblet cells, and an oil that stabilizes the tear film from the meibomian glands. I'll take you back to medical school. This sort of process sets up an inflammatory reaction that then feeds on itself through irritation, tear instability, and inflammation. And this can be quite symptomatic. From my own observations, from the deployment of stromal vascular fraction, patients have been markedly improved, especially our patient from Spain. And this patient was able to tell me specifically in follow-up that she has never felt better in 8 years. This is now a 2-year follow-up. This is a dramatic, and it could be a number of other factors, confounding factors, placebo effect, yes. And that's why I'm sort of here to do a little sales presentation. All of you, how many of you are ophthalmologists? None. But you may know an ophthalmologist who may be interested in some of this work. And the doorway has been opened between our translational research and then also some clinical practice. The deployment of these stromal vascular cells intravenously has extremely low morbidity or perhaps none. The issue of extraocular deployment or subconjunctival deployment is extremely low morbidity, virtually zero mortality, and is well within the technical expertise of every single physician here. And we'll show you that in just a minute. Now, I don't know why it is that when you do open cases, you do joints, and you're hammering and nailing and doing trauma cases, that if I show a video on eyes, 3/10 of you people will pass out. But truly, it really is not a difficult situation. These are before and after clinical photographs of our patients and some of our conclusions. But I want to show the video because it really is something that your physicians may be interested in participating with. Is there a video here that I can audio-visually present?
There you
Oh,
go.
here we go. Just let it go.
Don't click. Don't do it back there.
So,
Don't click.
oh, you'll take it back. Okay.
Yes, perfect.
Okay, so I'm left-handed. This is after the stromal vascular fraction has been harvested. This is a 30-gauge needle, short. This is a 1 cc syringe. And I'm just between the globe and the orbit. So it's a tight space, but you're aiming away from the eye. And I'm moving back and forth between the orbital septum.
You just mentioned anesthetic.
Oh, of course they're anesthetized. This is a little bit of topical drop anesthetic, 4% topical without preservative, and then subconjunctival injection with a lidocaine, tiny pinpoint, and you can go through that asymptomatically without a lot of discomfort at all. So you can see a little pinpoint, localized injection supratemporally on the conjunctiva. Lift up, aim away from the eye. You can see a little bit. See, goes in, and then the needle is advanced, away from the eye, feeling the orbit and the globe, away from the globe. If you hit the orbit, understand that the lacrimal gland has a palpebral and an orbital component. So the split by the orbicularis muscle. So you go superficial, and you go a little bit deep, and then you can bathe the lacrimal gland. How did I get this idea? Got this idea because of clinical research. In other words, sitting on my telephone at night, tapping into Google and looking at national clinical trials and also the National Library of Medicine. There was one study that was performed on dogs, and a clinical trial really didn't get going at UC Davis in regards to dry eye mechanism and treatment in dogs. Demonstrating sustained effect of at least 8 months in keratitis sicca, which is an excellent animal model for dogs, and as the same mechanism in human beings. So this is a deployment not only for, and that's just subconjunctival injection. This is a deployment not only of stromal vascular cells that are hoping to immunomodulate the inflammatory reaction in the lacrimal gland, but also limbal stem cells, which are also important for the treatment of this, or amelioration of this condition. So I think, has anybody passed out yet?
A little woozy over here.
Okay, you're losing? Okay. All right, so fundamentally, what we have is a request from all of you to try and get some of your ophthalmologists interested in some of this work. It's very, very rewarding to see that there's absolutely no other treatment for these patients other than this at this time.
Yeah, you're right.
There's emollients, there's drops, there's steroids, there's other medications that just don't seem to be able to do as well as some of our patients have done. So I would encourage you all to get involved. Contact me if you need, or Elliot, or Mark, or Sean, and we'll hopefully put something together for our patients.